Exactly 9 minutes past the top of the hour. You're right in time for our health conversation this Tuesday morning. We'll look at the kidney disease burden in our country, what interventions are being made as far as this disease is concerned, just what exactly also causes this disease in the first place, and where we are in terms of data and statistics so far. I am holding court with Ali Kapusia, who is the senior nephrology nurse, and right next to him is Donah Muguna, who is a renal nutritionist, and also she will be walking us through her journey as far as kidney disease is concerned. Lady and gent, welcome to the program.
Thank you.
Thank you.
I just want to latch on this particular conversation with you, Dr. Ari, particularly in terms of data and statistics. Whilst preparing for this conversation, I came across the fact that, is it 2.8 billion exactly? This is the amount that NHIF used as far as funding kidney disease is concerned. This was in 2021. In fact, from this particular report that they released on the analysis, it did indicate that this was the highest amount they used on a particular disease, and also they had to fund slightly about 300,000 Kenyans as far as dialysis treatment is concerned. Just from where you sit as nephrologist, what do you make of this data?
Thank you first for having me. It is true. I mean, I may not give you the right figures in terms of money.
Yes.
But this disease is very expensive. Mm-hmm. We are talking of twice dialysis, 2 sessions a week for every patient. So twice a week, and it's throughout, I mean, as long as you need it.
2 sessions a week.
2 sessions a week, and every session is 9,500 shillings. We are talking of the NHIF, the amount NHIF uses.
So in 1 week, it's...
In a week, we are talking of...
19,000.
Yeah.
Just in a single week.
In a week, we are talking of one patient. That's not a month, it's a week. And sometimes some patients may need even more sessions than one. So
when you say more, is like how many in a week?
3 times a week. 3 times a week. Sometimes some may need alternate days. Like you dialyze today, you skip tomorrow, the next day, like that. So the figure could, in my opinion, it is... it may not be. It may be higher.
Could be higher than even what was
could be
released
higher
in the analysis.
than that.
But you know that was 2021. So perhaps last year is something.
It could be higher.
Yeah.
And we are talking of the number of patients. At least we are lucky now as a country. We have the knowledge of kidney disease is really increasing because the awareness at first was. You may think it's a new disease that's coming up. It is not. It has always been there, but these are some of those emerging diseases that we are getting. I mean, the awareness is getting improved every other day, and we have so many patients, and on average, 10% of the population.
10% of the population.
Yeah.
You're saying knowledge is at least increasing steadily.
Yes.
But we'll come to the causes momentarily.
Sure.
Donah, you were diagnosed with this disease in 2013.
Yeah.
But from that point, I mean, up until 2016, that's when you got to the last stage.
Yes.
First of all, just even before we go to where we are currently, because now you are on dialysis, which, just as the doctor was mentioning, quite expensive. A lot of money being incurred just for this particular treatment. On that first test, as you got and you're pronounced as having a kidney failure, what was going through your mind in this moment?
To be sincere, I was too young to understand what's happening. So it was really, I didn't know what's happening. And again, at that time, kidney failure was not, the information and the knowledge about kidney failure was not as it is right now. Right now, you have a lot of people who are supporting you. The families are also taking it in a better way than they took it way back. So way back, kidney failure was like a death sentence to you. And it was not the best experience.
You're only 13 years.
Yeah, I was only 13 years. I was scheduled to do my KCPE.
In that moment of diagnosis?
Yeah, in that moment. And the kidney failure just came as a shock because I started urinating some discarded urine. So it was hard for me to explain. I was in a boarding school, explaining to the matron that my urine is discarded and I'm not on my periods. It was hard. So now when I went to the doctor and the doctor confirmed that you have kidney failure stage 1. And it's chronic kidney failure, so it's going to be gradual until it reaches to the end stage. It took like almost the whole year to accept that I'm sick. So whenever I'm given medication, I couldn't take my medication.
You are passing medication?
I was passing medication. And I didn't get the information that the way you keep on passing your medication, then that's the way your kidney failure is progressing to the end stage. So with me passing my medication, I also neared the days for my dialysis. And again, now dialysis is something else. It's not for the faint-hearted anyway.
We'll come to that in a short while, and even really what goes into that. But you're saying you just did pass your medication, and this is perhaps what neared you to dialysis, because right now you are at stage 4?
No, right now I'm in stage 5.
Stage 5. This is the worst stage?
This is the last stage.
The last stage, we can say that. Well, we'll come to that in a short while. But also, just listening to Donna's story, because she was 13. This is a young age. You know, there's some ages where you really could... Just how our mindset is set, I should say. There are some ages where you really wouldn't be expecting to hear of some certain kind of conditions. But is this a preserve of age? Or anyone just can get kidney failure or kidney disease? And even as you respond to that, what causes this?
Okay, that's really that's a very good question. That sometimes you may think some conditions come with age, and yes, they do, majorly. But kidney disease can occur at any age for lives. In fact, the youngest patient I've ever dialyzed was a 3-days-old kid. 3 days? 3 days old. And 3 days old who came with infection. It's called neonatal sepsis, and the kidney got affected and needed dialysis. So, but luckily...
3 days needed dialysis?
Yes. So, of course, they are not going to use the kind of dialysis everybody else uses. It's a special form of dialysis. And then in a week, this baby opened up. I mean, the kidneys opened up, the pre-existing condition was treated, and the kidneys came back luckily.
Okay.
So what I'm really saying is it can happen to anybody.
So there's no preserve of age at all?
No preserve of age. And the other thing that we need to know is that when you say kidney failure, we are talking of an organ, the kidney. So it is the kidney that gets sick. And just like any organ can get sick, you know, you can get your ears get sick, you can get your eyes get sick at any point. You don't have to be old to have your eyes, getting sick, or your ears, or anything for that matter, any organ in that body.
So then what causes this? What are we looking at? Because if I just speak your experience of a 3-year-old baby, much as we'd say age, I'm still trying to imagine, okay, this child, you know, they're infants. What would cause this? Or even as you take Donna's case at 13 years, you're literally still growing and developing.
Yeah, sure.
Yeah.
The thing is, in fact, I said 3 days, not
3
years.
days.
Yes.
So 1, 2, 3.
1 to 3 days.
Literally, yeah.
So 3 days.
Okay.
So the kidney disease, kidney can be affected by a couple of things. And it happens it can come as an acute case, whereby you have been okay all this time, and then something happens that affects your kidneys within minutes, hours, or even a few days, and you need an intervention. Your kidneys just crashes. And but that one has a potential. The word potential is really, I'm using it very carefully, because if it is not treated early, then you lose it. It doesn't reverse. So it's potentially reversible, meaning you can reverse it if you come to be assisted early.
Yeah.
If you delayed, then you lose it. You lose your kidney completely. Then you need kidney replacement therapy.
So early diagnosis is...
Early diagnosis, very important. Early diagnosis, early intervention, meaning you do the right things. Otherwise, even if you diagnose it early and you do not get the right intervention, you still lose it. Then the other stage of the kidney is the chronic kidney disease, which happens slowly. It doesn't announce, very slowly, very quiet, stealth. So that at the end of the day, you end up crashing. I mean, the kidney, by the time you realize, if you're not health conscious, by the time you realize you have no kidney, the tissue has been completely destroyed. So let me start by saying the chronic ones will has two causes majorly. One is uncontrolled diabetes.
Okay.
That's number one cause. Uncontrolled, meaning you can have diabetes, but then you control it. You diagnose it early. You may not control it. Sometimes some people tell you, okay, I've had diabetes, but I have been taking my medication. But when did you get to diagnose yourself of the diabetes? Because it could have been there for the last 10 or so years.
Just allow me to butt in. So
Sure.
if I'm getting what you're saying, so then it means if you diagnose also diabetes late, it could be a cause for chronic kidney failure. So you could be having 2 in 1. Okay.
Yes. In fact, number one cause, the whole world. That is statistically proven, scientifically, uncontrolled diabetes.
All right.
So, but if you control it, this word control is so important.
Okay.
When we say uncontrolled, it means if you got it early, you get to diagnose yourself early, and you took the right intervention, you're okay. You will go through it. You may never go to kidney disease. Because what really happens with diabetes is that it messes with almost every other organ. And you know why? It's because it affects the blood vessels. It narrows them completely to a situation whereby the very, very tiny blood vessels at the end of that reaches the tissues, they block. And therefore, when you block your blood reaching any organ, that organ dies. It lacks, I mean, you deprive it of oxygen, nutrition, and of course, the waste products remains there and doesn't get out that kidney. That tissue really dies.
Okay.
Not only the kidney, even the peripherals of people with diabetes, they lose their peripheral tissues.
All right.
Yeah.
So what's the second one?
The second one is uncontrolled. This word uncontrolled. Uncontrolled hypertension. Hypertension is blood pressure. So these are things that, in fact, kidney disease is majorly controlled. It's controllable. You can control it. You can avoid it. If you can be going to the clinics, not like in my village where everybody says, you don't go to, if you go to the clinics, then anakuuliza kwani wewe ni mama mzito, wewe ni mtoto mdogo. It's not true. That's a really bad culture, right? Okay. So we need to change our culture, whereby we know that to be healthy, you have to be going healthy to the clinics, or people will take you.
I hear
you have to take yourself.
I hear you.
Yes.
So for chronic kidney failure, which is also what you are diagnosed with, you're talking of uncontrolled diabetes and uncontrolled hypertension.
These are the two major things.
Two major things. So it means there are also other causes on the side.
Yeah. Okay. In my case, it was the nephrotic syndrome.
What is this?
Doctor will give explanation.
All right. So this is what led to this chronic kidney failure for you.
Yeah.
Of course, the doctor will explain that. But then let me still just stick with you, Donah, because you said, you were diagnosed early at stage 1, but it progressed up until stage 5. But you did say earlier on that midway here, you were not taking your medication.
Yeah.
So talk to me about how your support system was like, much as you really had not accepted that this is the condition you had, but how was the support system like? Were they pushing you to take this medication? Were they just, ukikunywa ni sawa, ukikosa? What was it like for you?
My support system was, they really wanted me to take the medication, but now the problem came around because I was in a boarding school, and in boarding school there is nobody to look if you are taking your medication or not. You have to be a grown-up by yourself. So you have to know, I have to take my medication, I have to take on my diet, which was also of concern because now I'm in school. So whatever is provided is what I'm supposed to be eating.
There was no special diet for you?
There was no special diet for me.
Had you talked to management that this is your condition, and so maybe I'm just trying to look at maybe if there are ways that this could have been averted, even for those that are in school. Like, had you talked to management that now this is a condition you're battling with, and maybe something special needed to be made for you?
Okay, I think even the management were like, she cannot be sick. So it was hard for anybody to believe that I'm sick.
Okay.
Because I was healthy. I was the healthy person who is the jovial person, and now all of a sudden you're sick, and you're sick from a disease that is termed that you will be sick for the rest of your life. So it was hard for also the management to take it that I'm sick. They're like, maybe it is a misdiagnosis or something. You just cope, let's see what's going to happen. But for us, we will try and do our best. Yeah.
I hear you. Daktari, when you listen to Donah's story, I'm beginning to get inclined that also in one way or another, institutions could at least help alleviate this burden. Why I ask is because I also did come across some certain figures that as a country, and of course maybe you said that this number could increase, but we were looking at 4 million as the number of Kenyans who have kidney disease, and this projection is actually looked at by 2030 this could rise to about 5 to 6 million. And so when you listen to such kind of stories that the numbers could rise, and here there are even institutions, maybe schools or even a workplace, which in one or the other could at least aid with this. Because when you look at the issues of special diet, good eating right, these are some of the interventions for kidney diseases. So when you look at these numbers vis-a-vis interventions being made, where are we? What are we doing? What could we do better?
Okay, thank you so much. What we have is the numbers may not increase, but they will increase.
They will eventually. They will.
That is it's given.
Okay.
So these numbers will rise, and they will really rise. They're already rising, and in fact, if you look at the number of facilities we have, a couple of years back, you would never have dreamt that these are going to be the numbers that you're going to have for the facilities for kidney treatment. But these are going to increase. We are going even to have people doing dialysis at home, okay?
Because now facilities they can't accommodate this people.
They're really stretched. Yeah. In fact, as a country, we should be, I can whip everybody to clap for NHIF and even this country. I mean, we're doing so well as a country. If you compare with most countries, our neighbors, I'm telling you, we're doing good. Especially when it comes to kidney disease.
In terms of treatment affordability?
Yes. Okay, affordability, because at least NHIF, we have an insurance coming in. At first, it was not there. Let me tell you, I was in this when everybody else had to pay cash. It was bad. You didn't want to see that. It was a very bad thing. You would see things happening at the benches and things that I will not.
And there's nothing much you can do about it. Yeah,
and
I get you.
Nothing you can do. And it was until sometimes the associations, we came up with associations and all this, and we went to the ministry, we talked to them, and they say, okay, so if it's a serious thing, we can now default even this treatment. It was at first only at Kenyatta. I'm talking of 25 years back when I was starting my career. Yeah. So it's really tough, but and we're moving steadily, because now we have like the nurses group, we have annual outreaches for kidney. We go around the country to do annual screening. Like the next few weeks now, we are going to have our World Kidney Day, which is going to be the first week of March.
7th of March?
Yeah. Okay. So, and this is going to be a very good media, process of telling people, indeed, there is kidney disease. Please do the basic things. Go to the healthcare next to you. Check your blood sugars. If you have diabetes, make sure you have a nephrologist in place. Bring in another person. Don't stick now with the diabetic person. Move to a nephrologist. Make sure you have a nephrologist alongside. If you have hypertension, make sure you have a nephrologist alongside as you keep the doctor who manages your hypertension. We've mentioned about children at school.
Yes.
This is a very serious thing. This is our future. The future is getting threatened, our children. So one thing that is important is that most of these conditions for children happen as a result of, and not only children, but over-the-counter medication.
Okay.
Treatment over-the-counter. Most medications are nephrotoxic, meaning they are toxic to the kidney. So if you continue taking it, you're destroying your kidneys. So I don't know how many children just get infections. They get sore throat, and it's not well treated. That is going to cause what just caused their kidney failure.
Okay, really?
Yeah. Yes, you get sore throat, and it's not treated. It's a bacterial disease, and of course it moves through the bloodstream, and that blood goes with the bacteria, lodges in the kidney, and the bacteria affects the kidney. So and nobody knows, it doesn't show you.
So this over-the-counter, I really want to come to nutrition in a bit, but we have to get this one. So this over-the-counter, just the way you're talking about the sore throat, especially in times of colds, you would really hear of such cases, and you're so prevalent to getting amoxicillin to just soothe the throat, and after 5 days, and actually over the counter they'll tell you after 5 days, 7 days, imeisha. So consistent in doing this could actually affect your kidneys?
Yes, in fact, the thing is, we are not privileged to be having amoxicillin. We are disadvantaged
to be having it.
To be having medication over the counter.
So you're saying something that I don't really want to call it simple, but just let me. Something as simple as what we call the sore throat, and we know Ampiclox and amoxicillin could treat this. You go to the chemist, you get your dose for 5 days, and we think it's good enough, and actually indeed after 7 days you're good. This has a ripple effect?
Yeah, you see, when you do self-medication, it's usually wrong. It's unprofessional, first of all, because you do not know the dosages. You are not sure whether that condition really reacts to, is sensitive, the bacteria is sensitive to what you're taking. You do not know first whether this is even bacteria or it's Is it bacterial or is it viral? So it's a wrong diagnosis in the first place. Unless if it is prescribed, that's okay. Because you can then go back to the clinician and tell them, okay, I've taken for these days, this is happening. So, and they can control.
I hear you.
And some medications may not be the right, I mean, the dosages are very important. Some dosages are toxic.
I hear you.
So that's it. So I think, like you're putting it, we need to be going now to take our campaigns to schools.
I hear you. That's why you have this day on 7. And you've just oriented my mind to think about having a conversation on over-the-counter drugs and what this means in the long run. But we have like about 4 minutes to finish this conversation, and I would want us to do that without talking about nutrition. Donah, you are a renal nutritionist. So we're talking about the kinds of foods that are equally very important for the general public and largely also for people battling kidney disease. What are we looking at in terms of diet?
Okay, renal nutrition is way complicated. Since if you look at a dialysis patient, the fluid intake will be toxic to them. But if you look at the person who has done their transplant, then fluid is best for them.
Okay.
So for renal nutrition, it's something that you need to have your nutritionist working with you, because something simple like a banana can lead to your death.
Sure.
Really?
Yeah. Banana and avocados with a patient who is on dialysis, that is a death sentence to you, because it's so high in potassium.
Okay.
Which is the #1 killer for patients with patients on dialysis or patients with kidney failure.
All right. So even as we talk about fruits and them being good for your health, there are certain categories that don't touch. Don't even look at them.
Yeah.
Okay. And this is specifically for a patient on dialysis.
Yeah.
So for you, you are on dialysis.
Yeah.
So these are fruits that you don't even look at all.
Yeah.
Which ones are better?
Now, a dialysis patient, the only fruit which is better for them is an apple. The rest, yes, you can eat, but on a very minimal amount. But for the banana and the avocados, you are not supposed to look at them.
I think that's important, because sometimes you go to visit a friend and you've bought all sorts of fruits, and that's why you're not let and dizzy, you know. So just let me look at your plate. How does it look like in terms of a balanced diet, also just with the dialysis ongoing?
Okay, my plate will look like, I'm not supposed to take a lot of red meat, not even a lot. I'm not supposed to take red meat in real sense. So my plate mostly is consistent of white meat and a lot of greens, which are also cooked in a special way. Not cooked like the other
kind of vegetables.
Yeah. my greens have to be branched so that I can get rid of some potassium and some urea in them.
Okay.
Then the other thing is that I will be taking maybe some ugari, the carbs, they are okay. But now, whenever you're taking meat, you have to take a very small amount of meat.
This is white meat.
Yeah, even the white meat, still you will take a little amount of white meat, because of the ureas. Okay, for a dialysis patient, the point is your kidneys are not working. So whatever you take inside your body stream will stay inside there until the next day when you're going for dialysis.
Or now it makes sense why you talked about alternating, like you can go Monday, skip Tuesday, go Wednesday. That is expensive.
Yeah. Okay, for me, I go to pee after 3 days. That is it.
After 3 days?
Yeah, because I don't pee normally. So the machine is what will assist me pee. So I pay for peeing. If I can put it in a layman's language, I pay to pee.
That which you take as normal.
Yeah.
Let me tell you, we need to have part 2 of this conversation. We are strapped for time in this moment. I wanted us to talk about the cost implication of dialysis, talk about the transplant, talk about the statistic of living in low-end areas and how this is, there's a lot to talk about. But we really have to cover at this particular point. And I definitely appreciate your time, Donah and Dr. Ali, just for your valuable inputs into this conversation. Like I said, part 2 is necessary to explore further and just also let Kenyans know where we are and basically what you can do, to also just assist yourself. Maybe you could prevent this as an individual. Nonetheless, thank you very much.
Okay.
I have been speaking to Ali Kapusia, who's a senior nephrology nurse to my far right, and right next to him is Donah Muguna, who is a renal nutritionist, definitely also just talking to us about her experience battling kidney disease for the past 8 years, where she's been on dialysis for the past 8 years. Good place to end this conversation, and ultimately good morning Kenya from me and on behalf of the entire team. Asante sana, till tomorrow. Good morning.